Welcome everyone to this AMSE lecture. We are very happy to have V Banerjee with us today. Abhijit is a Ford Foundation International Professor of Economics at MIT. He is a co-founder of JPAL, the Abdul Latif Jameel Poverty Action Lab, and he received the Nobel Memorial Prize in Economics in 2019 with Esther Duflo and Michael Kremer for their experimental approach to alleviating global poverty. Abhijit's work has had a profound impact on the practice of economics and on the practice of policy. At the beginning of his career, Abhijit was a theorist. He notably proposed a beautiful model of herd behavior. But at some point, he started doing RCTs, randomized controlled trials. His work and the work of many others helped economics mature into an experimental science. Behavioral economists brought in vitro testing into economics with lab experiments, but with RCTs, Abhijit and others brought in vivo testing into economics. And RCTs are a great way to provide concrete answers to concrete questions, such as how to help children learn better, or how to reduce deaths from malaria. Now, there was originally some resistance against RCTs in the profession, but I think more and more economists have realized that, yes, RCTs can be combined with theory. They're actually great for structural estimation. Yes, RCTs can account for spillovers and equilibrium effects. And yes, RCTs can be used to answer big questions, such as whether poverty traps are real. Now, RCTs are a great tool, but they are not the only one. And in their latest book, Good Economics for Hard Times, V Banerjee and Esther Duflo leverage research from all over economics to help address our main social problems. This book was written before COVID. Times were hard then. Well, they are certainly harder now. And we need good economics more than ever to address the challenges of the post-COVID world. A few words on organization. Abhijit's lecture will be followed by a discussion by Roberta Ziparo from the Aix-Marseille School of Economics. We should have some time at the end for questions from the audience. If you have a question, please write it in the Q&A. And that's it, Abhijit. We are very happy to have you with us. You have the floor for an hour and 15 minutes.
Thank you. Thank you for that very kind introduction. I figured that in the context of what's happening in today's world, there is obvious reason to be interested in healthcare, and in particular in the question of delivery of healthcare, not just of course the technology of healthcare, but also on how healthcare gets delivered. Who, for example, how do you get people to get vaccinated? And that's a question in which trust and efficiency are immediate, in a sense. So when I say trust and efficiency in the market for healthcare in low-income countries, you'll see reverberations of the ideas here across the world. This is, I should say, joint work with Jishnu Das, Jeff Hammer, Reshma Hosam, and Akash Mopal. And it's, in a sense, a confluence of several strands of work. One very important strand, which will be very important, the first part of it, is work that Jishnu has done for the last 20 years on measuring quality of healthcare in developing countries. It's related work that I did with Angus Deaton and Esther also 20 years ago. So there is work on measurement, and I will spend quite a long time talking about just measurement. Before I come to any interpretation, I'll tell you what some facts are and why it's sometimes challenging to even document those facts, and what makes those facts maybe more striking than we expected when we started out. And then I'll suggest an interpretation of the facts, just a suggested interpretation. I won't claim that this is what's exactly happening, but it has the advantage that it sort of ties together the facts with some notions about trust and efficiency. And then I'll show you a little bit of evidence from an RCT, which we had done on trying to improve, well, which tried to improve both trust and efficiency, and you'll see what it did and didn't. And finally, I'll tell you a little bit about why maybe this is relevant for questions of policy. I think a lot of healthcare, I think the background here is useful, which is that healthcare, when you think of healthcare in France or in the US or in UK, there are different models, but in each of them, I think the key ingredients are insurance, various pricing of services, and while there is a market, for example, for these services in many countries, it's not typically a market for fee for service. So it's most of it is already paid for in one form or the other by the state or by individuals. Very little of it is you like buying a repair of your car, which is, and even less like buying an apple. So it's very little of it is like go or getting a haircut. I think to take an example that is very close in some sense, getting a haircut is not at all in France. It's not at all like getting healthcare, and I think that analogy is misleading when you think of most of the developing world, where getting healthcare is very much like getting a haircut. There are multiple providers, and even in very remote areas, multiple providers. I'll give you some numbers. The qualifications of those providers vary a lot, and there is no presumption, for example, that they have medical degrees of any kind. The insurance essentially plays no role in any of this. This is primary care. There's not that there is no insurance in these markets, but because partly of the difficulty of regulating markets where there are many participants and there is free entry, essentially, people can come and claim to be a healthcare provider, insurance systems don't want to tackle primary care. Insurance does provide secondary and tertiary care in many of these markets, but not primary care, or at least partially provides secondary and tertiary care, not primary care. And as a result, this is, the market is effectively out of both the regulation by the state and regulation by HMOs and other private providers. So there's really people set their own prices and get whatever quantity they get, and the incentives are provided directly by the market. So in that sense, this world is perhaps, as I said, much more like the world of getting a haircut than that of getting healthcare in France. Think of it much more like a haircut. As I said, we'll start by showing you data. And the data comes from a large number of studies, all of which Jishnu Das was involved in, some of which I was involved with, etc., from 5 locations in India, but also from China and Kenya. And the important word in that slide is standardized patient. Standardized patients are essentially actors trained to play the role of a patient. The reason you'll see that makes a very, very big difference to everything that we find. So it is very important to understand what they are. They're really trained by a kind of a set of a combination of health experts, but also very much acting experts to be to claim to have certain conditions. So what you do is you show up at the provider claiming to have certain conditions. You can easily see that that limits in all kinds of ways what we can do. For example, if you say you've broken your leg, it's very implausible. You can't claim to have broken your leg, and therefore there is you can claim to have a cuff, you can claim to, but even that's a little bit hard sometimes if you can't cuff at all during the, but there's a range from, you can't have a runny nose, for example. Runny nose is easy to observe. So there's a very clear limitation to this. On the other hand, it does have the advantage of having being validated, in the sense that you can connect this to other things that these practitioners do. I don't want to go into the validation exercises, but also to potential concerns about, are these being taken seriously? Is it the case that the practitioners just see that these guys are fake and therefore don't behave in the same way as they would otherwise? And so there is an attempt to validate that. I won't tell you details of that here because I'll take those are whole papers which are then try many different approaches to this validation. But the second advantage is, if you believe the validation, then it has the big advantage that it's really what they do rather than what they say they will do. And that's a lot of the healthcare literature has relied on what people say they will do as against what they will actually do. And you'll see that that makes a big difference. I sort of said this, so let me, but still summarize that there is a key fact that I think I'm going to show you is that the quality of care is very low. And I don't think you'll disagree with that. And highly variable. Sometimes it's better than others. However, it's almost always inside the envelope of what we think the providers, what we know the providers know. So when you ask them how you will treat the same condition, they say X, and what they do is usually Y. And that wedge is what is going to be of interest to us. And then, well, I'll come back to the rest of this. Let me continue. This is the idea that we need to, that there might be inefficiency in healthcare markets is not new. There's, in a sense, it goes back to Arrow, 1963. So it's a very hallowed tradition in economics. The healthcare markets will not necessarily deliver the right outcomes. And, for example, there is a large literature both arguing theoretically and empirically that there is that patients, especially in insured settings, have very little incentive to monitor, whether they're getting the right thing or not. In the sense that as long as they're getting the right thing, if they're getting more than that, there is no reason for them to push back. So, and that creates incentives for healthcare providers to overtreat. And that's sort of the core concern in a lot of the literature from the OECD is that, which is that there will be overtreatment. We will find the opposite. We'll clearly find evidence of undertreatment. Now, that's related, as we will argue, to this other fact on which there is more recent, a bunch of recent papers suggesting that, that the patients are often, they lack trust in healthcare providers. And a very nice paper this is misspelled, is Alsan 2018, which shows that in the wake of the Tuskegee experiments, the African Americans had just became, once they were revealed that these experiments had happened, they stopped trusting the healthcare system and not getting necessary checkups and prevention. So it's a really beautiful paper showing that African Americans in the US were underusing healthcare because they were actually suspicious of the motives of the doctors. And so that's going to be a key part of our story as well. So there are papers which focus on the lack of trust aspect of it. And then there's a bigger literature on just mistakes that providers make. For example, Mulanathan and Obermeyer is a nice paper. So what we're going to talk about, as I said, is the effect of trust, the lack of trust in providers on the practice of healthcare. So how do you respond if you're a provider, if you know that your patients are suspicious of you? Arrow talks about something very related. And that's, it says that the physician cannot act or appear to act so as if he is maximizing his income at every point of time. He has to signal his intentions to the buyer. So, and that signaling question is going to be key to the model I'm going to get to it in a bit. So keep that in mind, that what we are interested in is there is a literature now on lack of trust. We want to look at what lack of trust does on the supply side. Let me come so I'm going to start with the facts now. So these are some maybe striking and maybe implausibly dramatic facts. In a sense, 80% of contacts are with fee-for-service private sector. This I told you already. 72% of providers in rural areas have no medical degree. 18% have some medical degree but not an MD degree. And 4% have an MD degree. This is not because these are places where there's no one. There's typically a bunch with no degree in every village in various parts of India. Public providers are more qualified and offer free service, but they have a 20% market share. Where there is actually a public health center, it's much higher, but people don't travel even to the next village to get public health care. And the reasons for this are interesting and important to discuss. They are part of what we discuss in our work with Angus and Esther, but this is not what I'm going to talk about today. Those are sort of just different locations across India. Now this is across India. You can see the graphic. So the green is no degree, and you can see that essentially, other than Kerala, where essentially everybody has a degree, almost everywhere else, no degree is the standard. Okay. The data. The data comes, as I said, primarily from these, well, this comes from two things. One is the standardized patient visits. So 2 or 3 standardized patients typically will visit a healthcare provider. These are different locations, so slightly different protocols. And we will say, for example, I woke up this morning and feel a crushing chest pain and was feeling very anxious. That's your absolute, you know, somebody, a healthcare provider would, in France, will probably recognize immediately as a sign of impending heart attack or actual ongoing heart attack, and would suggest that you take an aspirin and go to a hospital immediately. That's the treatment protocol. So then, you know, you show up, the provider does whatever it does, he recommends a treatment. As I said, there is no evidence that, you know, the provider think that the patient is faking it. To make sure of that, we don't send multiple of these patients to the healthcare provider at the same time, because then, given especially that there's very few visitors, he would wonder why there are so many outsiders coming. But it's not, on the other hand, it's not unknown for outsiders to come to them, because you come with a story which says, I was visiting a friend, a relative, you know, my uncle, and I'm feeling very sick. And can you take a look? He suggested that you come see me, or I was visiting a friend and I came to see you. So there's a cover story that's given in all of this, which is important to make it credible. It also means that these are typically people who are so in this data, the variation is going to be limited, because in 2 ways. One is that we try very much not to, something we could have done differently is we could have varied the patients and provided signals about, you know, the ability to pay. We don't do any of that, because we don't want to attract any attention to these people. So we minimize that, which is maybe right, maybe wrong. But it means that we are going to, everybody tries to look the same. They're given the same training, and they are, and the second thing is what I said already, their conditions are very much limited by this. You cannot claim that you broke a leg. Once this is done, and this takes a while for the reason I said, which is you don't want to send a bunch of strangers on the same day. So the strangers have to be spaced out over a month or so, 2, to make sure that essentially, you know, the provider thinks, okay, fine, you know, 1 more person in a month who's I haven't met, that's okay. If 4 of them showed up in 2 days, I would start worrying that something strange has happened. And then after this is done, 2 surveyors visit the same provider and do what is typically done in such cases to look at their ability to treat, which is to complete a medical vignette. This is the standard procedure. Surveyor 1 says, surveyor 2 will be your patient. You should treat him like a real patient. And then they say exactly what the standardized patient said. But in this case, it's known that they are pretending. So that's a very different setting potentially. These are the samples we'll talk about. Some places there's both public and private. Some places there are, in China, there's only public. In many places, there's only private. They're rural and urban. Some are, I think in all cases, there's trained and untrained, except in West Bengal, where the RCT was carried out and the focus of the RCT was on untrained providers. Therefore, there was an attempt to keep them to choose people who needed training. So therefore, that there's only untrained, but typically there's variation in training among these people. And then there are 3 conditions, typically asthma, diarrhea, angina, TB. These are the conditions that typically show up, each of which had, yeah. Now, we're going to show you, before I show you data, let me tell you a little bit of the measure. The correct treatment for angina is take aspirin, get an ECG. We will be, because in some sense, we already, as I said, incorrect treatment is so predominant, we take a relatively lax definition of correct. So at least one element of A and nothing else. Okay, so as long as you are named something as correct, that's good enough. This avoids, for example, issues about, I could think that you have, this something is very expensive and therefore I endogenize your demand at some level. So this is tries to be bare minimum, rather than if there were 3 different medicines and one was less important than the other, then as long as you name one of them, that might still be okay. So it's taking a specific and relatively conservative view of being incorrect. Over-treatment is you get the right thing and something wrong. And incorrect treatment is you name nothing in the right list. And we got the right list by triangulating kind of doctors at Harvard Medical School and in Delhi, and in China, the kind of the capital, the healthcare experts in each of these areas. So that's where the list comes from. As you can see, the core fact is that incorrect treatment is overwhelming. Kenya, which is the urban Nairobi has maybe less than 50% incorrect treatment. Everywhere else is over 60%, typically closer to 70 and 80 or 80%. And a lot of that is giving an antibiotic. I think the one piece of incorrect over-treatment is, a lot of the over-treatment is actually giving an antibiotic. A lot of the incorrect treatment is also giving an antibiotic. So in both cases, you get a lot more antibiotics than you should. And that's a separate issue in itself. Antibiotic resistance is rising, has risen. And this is a part of the reason is that, there's absolutely abuse of antibiotics. So that's I'll show you a little bit more. This is less of here there are slightly different choices are made. So when you want to look at the cost implications of this, just to see whether or not the how important is the incorrect or over treatment? Is it just that, you know, I don't suggest anything to you, or is it the case that I actually make you spend money? So if I say, don't do anything, go home and rest, that would be incorrect treatment in our definition, even though in Boston, whenever I go to my doctor, that's what they always say. So that would be incorrect treatment, but it would be incorrect treatment that would be free. And we are going to count. So here what we're trying to do is look at whether or not the treatment is, so typically in every visit, by the way, all the idea that I will do nothing is almost never practiced. They give you something, often an antibiotic. So so it's not, but, and now what I want to do is just define, make some definitions. If you give something that's needed, then the full cost of the visit is treated as necessary. If you give something that's unnecessary, but something that's needed, then just the marginal cost of the additional thing is counted as unnecessary. And then if you don't do anything useful, then the whole cost of the visit is treated as useless. And you can see, you know, the example given suggests that there is a lot of you know, kind of margin of error in this. In particular, if you, for example, to give a child, if the doctor takes the view that we will just do triage, first try something, if it doesn't work, we'll do something else, that's going to you know, this could be actually correct treatment. We'll treat it as over treatment, but it's not going to be necessarily over treatment. Sometimes the cough syrup is useless, but it's useless only because ex post he was given the antibiotics. So in that sense, it's less useless. You know, if it worked ex ante, it could have worked. And if it worked, then that would be treated as being the right treatment. So that conceptually, it's not obvious how to do this correctly. Just to give you some orders of magnitude, again, between 70 and 90% of the expenses are avoidable, according to our calculation. So there's a lot of waste in this system. You know, most of the money is wasted. It's also high for qualified private providers, by the way. So there's some data on, and in the public sector is lower, but not much lower. And you can see that even for qualified providers, that number can be as high as 40 or 50%. So it's not necessarily just unqualified provider. Now, the next question, so that's just to say that there's a lot of incorrect treatment. Next question is this due to lack of knowledge? And obvious thing we can do is we can see, because we ask them, what would you do in such a situation? We can compare that. We can say, you said you know, we don't actually do this to the person, but conceptually what we're doing is, you said you should do A, B, and C, you do C and D. Or do you do, you know, how much of A, B, and C, when you say you do it, do you do? And that's obviously the question of how much of this is fixable by just making people more, you know, training them better, giving them more knowledge, and so we can do both this sort of look at the correlation between what you say and what you do, and we can also see if, in particular, if you happen to know a lot, do you do a lot less of the useless things? Is it the case that the performance in particular is, the bad performance is concentrated among untrained people and more trained people do much better? We already saw that, even trained people do pretty badly, but at least we can look at this more specifically. So this is what we call the no-do gap. Know is what you know, do is what you do. Know is what you say in the vignette, do is what you do to the standardized patient for the same condition, always. And you can see that there is always a gap. The gap is often very large, so you might know the correct answer 70% of the time, but do it only 25% of the time. And that's true in all the data sets we have. And it varies a bit by private. And there's no sign here. You can see that the most trained people are actually for example, the private trained people are among the worst offenders in this. They do very little of what they know. They know more than others, but they don't correspondingly increase what they do. The other thing you can do is then run a regression. So let me skip this one. This is a four-way classification, which is correct. You say the right thing but do the wrong thing, and the other way around. This confirms the same fact. But go to this, which is run a regression, where what you do is you put what you do on the left-hand side and what you know on the right-hand side. This is just a correlation, but it's a correlation that allows us to estimate theta, which is the effect of increased knowledge and better performance. Now, the one problem with no is that people are often, they forget one thing when they say it, so no is often poorly measured. So what we can do is we can use the fact that we have multiple measures of no. We do this particular measurement of no twice. That allows us to have an instrument for, one measure of no can be an instrument for the other. The concern here is that because no and do are both binary variables, or almost binary variables, the standard IV tends to be upward biased. So what we do is then we put a little more structure on it and estimate this by GMM. And then we can apply the same measure of measurement error to other samples and see what they would imply. So we can try to correct for that in other samples. And you can see that basically a reasonable coefficient from the GMM, let me assume that the GMM is the right one, 20% of your increase in performance is in knowledge is turned into performance. So something like a coefficient of 0.2, maybe 0.3, but no more than that. Your knowledge goes up by a lot more than your performance goes up. That's bad news in some obvious way. There's no, a lot of the spending is unnecessary, and training doesn't seem to help a lot. I mean, it helps, but not enough, maybe. The obvious question now is there reward for extra effort? Maybe these people are just doing the optimal thing because nobody is going to pay them for the extra effort. And I want us to look into that first more naively, and then maybe through a lens of a model. So what what we're going to show you is data on 3 outcomes and the price. And the price includes your entire the entire package. We can do it in different ways again. So typically the healthcare provider actually gives the medicine. He doesn't actually write a prescription, he hands the medicine. Partly he buys them in bulk, gets them cheaper, partly his prescriptions are worthless. So you're not actually, so he buys it on the black market or some other gray market and sells them because he's not actually allowed to write prescriptions. So he buys the medicine on gray markets and sells them. So in either case, so typically we should just include everything he does in what you pay, but you can do it differently. You can leave out medicine. This is there. I won't spend too much time on it, but Jishnu has a set of papers on which he tries to do it in multiple different ways. So the only thing, this should be self-explanatory, except for the maybe now in the US, there is a very strong emphasis on checklists that you should, when you treat somebody, you should just check off all the things that you need to do. So we could ask, did you ask those questions? Did you do those exams? So there's a specific set of checklist steps for each of these conditions. And I'm going to use the, in the case of the standardized patients, we know how many they complete, and we can see what price they charge. So I'm going to do this in multiple different ways. So if you, if you think that the first thing you see is not quite what you would like to see, wait. So this is the relationship between examination time and checklist. So if you examine longer, you complete more of the checklist. There's no particular surprise there, nor is there surprise that if you complete the checklist, then the treatment is more likely to be correct. So both of those, these are just correlations. You may worry that the people who complete the checklists are also more likely to be more serious, and all of those are true. So there's no particular causal claim being made here, but it seems like the market is behaving, there's nothing here that jumps out as suggesting a reason why you shouldn't do your work. So there's if you do your work, it seems like you get better outcomes. Whether that's causal or not, I don't know. Likewise, if you do work longer, you get paid more, and you do more of a checklist, you paid more. These are all different locations. Each curve is a different location. You can see the fees checklist relationship is once you standardize the fees to a standard deviation of the fees, they are strictly on top of each other. They're all going exactly the same direction. Surprisingly uniform relationship between checklist completion and fees. So now, why do I show you this? Because I want to make the claim that checklist completion is observable. You can see how much time he's spending. At least the time is observable. So if I'm a patient, I can see that the person is putting more effort, he's doing more checks. Maybe I don't know exactly whether the right checks or not, but I can see that he's spending more time. And I seem to be willing to pay more for it. Whether that's, again, this may not be causal. It may be that these are people, very different people, but nonetheless, so I come back to the causal question in a second. There's not much variation across people who know know more. They don't, the relationship between checklist completion and correct treatment is roughly the same. If the checklist is exactly, if you say the right things, do you do much better? No, you do somewhat better. And again, there's wide variation in it. You can see that some people who know a lot, we are comparing people who know and know for sure. So people who say, give the right answer in both the times they were asked the question, those people don't do much better than the ones who say give the right answer once. So it's not the case that somehow knowledge, and there's enough variation. So you can see that some people who know a lot do very little, some people who know little or relatively little do a lot, etc. So it's not totally just knowledge driven. So in those curves, maybe just to emphasize, the kind of bell-shaped curve is the distribution of the fraction of population who complete certain amount of the checklist. On the right-hand side is that's on the right-hand scale. On the left-hand scale is any correct treatment, and you can see that there is, when you do correct treatment, you get more. It doesn't matter so much. When you do more checklists, you get more correct treatment. Doesn't matter how much you know, and there is variation, large variation among people on how much they do. And that's what you should keep in mind. This is this is with fixed effects. Okay, so you might be worried about the two places where we have multiple observations on the same, for the same provider, for the same condition. The provider, when the same provider does more, which happens, maybe the provider has looks at the patient and thinks the patient is richer or whatever, they charge more as well. So when you do more, you get paid more and you get better outcomes. So it's not, there's at least prima facie, there seems to be incentives. So if you do more, you get paid more. When we do the hedonic regressions, all this is confirmed. The checklist completion is, you complete more, you get a higher price. You spend more time, you get a higher price. You do more correct treatment, you get a higher price. Any of those are correlated with. So the price is, the market seems to have exactly the features you would expect, which is, better provision is rewarded. The fixed effect regressions are next, and the fixed effect regressions are exactly like the cross-sectional regression. So it's not because we are comparing apples with oranges. If I put the fixed effect, what I'm doing here is I'm superposing the fixed effect with and the non-fixed effect, the cross-sectional regressions. And you can see that they look non-parametrically the same. It's not just that they have, when you estimate two clouds, you get different, the same, coefficients. This is really, they look very, very similar. You have to squint to see differences between them. So it's not the case that this is a result. So in some sense, the same person doing more gives you, when he does more, he gets paid more. So it's not the case that I have a fixed price for my whatever I do, I get 10, and whatever Jan does, he gets 15, and therefore, when you do the cross-sectional comparison, you get a coefficient. This is when Jan does 10 and Jan does 15, he gets more when he does 15. And the slope is identical. So there seems to be a price per hour, if you like, or minute, which is standardized, and those who do more, or when I do more, I get paid more. And there seems to be little variation. Let me not try to spend time on this, but you can see that at least this is outcome price charge is increasing with in both of these samples now with fixed effects and without fixed effects. You can see the coefficients are extremely similar, and it makes, you can do different ways of estimating it. Really, very little makes a difference. So it's the case that you do get paid more if you do more. Now, one reason, so that says that if I were to do more, I would get paid more, or at least it looks very much like that. Why don't they? So one reason could be that they're busy. They're just treating patients all the time. And maybe it's more desirable that they treat more patients than just take their time. So here's in these two locations, we also look at how much time they spend a day. So the peak in Birbhum is 30 minutes a day. The peak in Madhya Pradesh is 15 minutes a day. And they typically spend whole day in their office. During the vignettes, we had people sitting in their office all day. So it just doesn't seem to be the case. So in other words, if you estimate, now it could be the psychological cost. It doesn't have to be, maybe every time I treat a patient, I'm exhausted. It should still be so I can't rule it out, but the implicit wage to not do any more would be $6 per hour. In these locations, roughly the earnings are close to minimum wage, and minimum wage is $3 per day. So $6 per hour. They are in the office 6 to 8 hours versus $3 a day. That's what they're making. So if you wanted to say that they are, what is the wage what is the marginal cost of time at which they would not do it? That would be $6 a day. What are they getting paid? $3 and $6 an hour. What are they getting paid? They're getting paid $3 a day. So it doesn't seem close. Maybe I'm missing something, but it doesn't seem anywhere to square this circle. Okay, so now what I want to do is, as promised, I'll tell you a little bit about a model which would at least be consistent with these facts, and then show you some results for our city. So the motivation for the model is a quote from an anthropologist who says these things. So I'll just read a part of it. A patient straight away, if I tell a patient straight away that they have to go to get tests that cost 10,000 rupees, he will run away and not come back. So I give them some medicines and tell them to come after 3 days. Then I slowly ask them to get the tests done. So in other words, building a reputation, that's a clear statement about building a reputation. If I do something that has some ameliorative effect, even though if it doesn't make it better, and so on. So I'm going to try to show you a little model of that. 2 types of providers, 2 healthcare conditions, mild and serious. Mild conditions have a lower cost of not being treated. you have two levels of effort. If you do the first level of effort, then you will only diagnose if the condition is mild. If it's not, you won't be able to diagnose any of them. If it is, so there could be many different mild conditions, many different serious conditions. If I do the more higher effort, then I'll be able to diagnose both. Diagnoses can be, only correct with some probability. And if you put in a cost of effort, you pay that cost. The high type is defined to be the one that's more likely to correctly diagnose, and directly diagnose, I'm going to equate to correct treatment. Since everything is noisy here, it really makes no difference to the analysis. I could put another stage of noise by having treatment in it, but nothing. Effort is observable, but type is not. The patient lives for two periods and has symptoms of disease in both. That, of course, is just definition of period. The discount factor is all that's connecting those periods. So the disease can be of either type. The patient doesn't know. And he has always an outside option of taking V bar, which is going to the hospital some distance away. That's more costly, but maybe it has some predictable outcome. The second period, they have a choice of visiting the same person, visiting a different one, or taking the outside option. The difference between the periods comes from the fact that the patient observes the provider's treatment and whether it was successful or not. So did it do something good or not? And then you can decide that, I go back to the person either with a different condition or maybe a recurrence of the same condition, etc. The contracts are key. They are fee-for-service contracts. In other words, you can only be paid when they deliver service. You cannot say that, okay, you reveal your type and I will pay you a fixed amount, and then I won't go to you. Or if you reveal yourself to be a low type, I won't visit you, but you still get paid. Those are not ruled out, and that's key. So, and the decision is ex post. There's no commitment. So if you reveal yourself to a low type, I cannot commit to come to you. I'm just going to walk away and go to someone else. So zero commitment and no payment for without service. The provider's condition on the contract on the past experience potentially, and based on that and on their own type, they provide a contract which has a claim potentially about their own type, a proposed effort level, and a fee. So I suggest in this period, I will treat you for 10 minutes and I'll charge you 50 rupees. And I'm a high type doctor. Anybody can say that. But yeah, that's so. The patient minimizes the cost of being sick, less the cost of fees, plus the cost of fees, and there's some discounting potentially, so that it may be a long time before she comes back. The provider maximizes fees, less cost of effort. I'm going to make some assumptions to make the model just less cases. It's all very easy to analyze. Randomly selected provider is only worth seeing for a low effort task. So if I don't have any prior information, a known high type is worth a high effort visit, and a known low type is worse than the outside option. So if you declare yourself a low type, I'm going to go to the hospital or go to some other person. The basic structure is that it was a signaling game, but with the signaling game, remember here there's two periods and there's no commitment here. So, I can try to signal my type. I cannot be paid unless the patient comes to me. this is what limits the scope for separating equilibria. Typically, we think of signaling games, especially I'm going to use a particular refinement. You would think that those tend to pick separating equilibria. Here it's going to pick pooling equilibria. We're going to apply divinity just because I like the name. Otherwise, we could apply choke creps, etc. We could, nothing particularly different will happen. I'm going to not go through so much of the details, but you see exactly how I use it in a minute. The second period, the two types have identical payoffs because they are both going to, you're going to be paid at that point of service, whether you get better or not. This will turn out to have the consequence that only a pooling outcome is possible in the second period, because if the low type reveals his type, he gets 0. So he will never want to reveal his type. And so as a result, there will be the high type. There could be partial separation, but if there were partial separation, then there will be an incentive. You still get paid what the low type gets paid in a partially separated equilibrium. The high type will get paid 0 as well, like the low type. But if you're getting paid 0, you're always better off of moving to a pooling equilibrium, which will satisfy divinity, because both types have exactly the same incentive to move to the pooling equilibrium. Therefore, there is only pooling equilibria possible. That pins down what happens in the second period. Given that, we can now analyze the first period, which is, again, there is some possibility of separation now, and there can be separating equilibria. The way this will separate is, you'll say, I'm going to lose money in the first period, but that then buys me credibility, because if I were a high type, I'm more likely to cure you, and you probably won't come back if you're not cured. But if you're not cured, you will think I'm worse than the average type, and therefore you are going to go to just someone else. There's no reason to come back to somebody who's failed to cure you. So so if it is the case, that's not quite right, but think of that as being the extreme limiting condition, is that, the only way we're going to get separation is if it is the case that the high type is more likely to be employed in the second period. That's what gives him the incentive to separate. He will therefore charge a very low fee in the first period and say, I will make it up in the second period. You're going to come back, and you're going to then pay me the market, the equilibrium price, but that's going to be enough. If I were a low type, I wouldn't charge you this price, because if I charged you this price, you would then, in any case, I probably won't be able to cure you, so you'll never come back. So I'll lose money in this period, and then I would not be. So separation is possible, but perfect separation is not, because given the structure of the model, if there's perfect separation, then there's no updating from failing to cure. I know already you're a high type. You fail to cure me, there's some chance you would fail. But therefore, I don't update on your type if you fail to cure. But since I don't update on your type, it must be the case that both types earn the same amount, because the L type could do just like the H type. But that means, again, that so full separation is never going to be possible. There could be partially separating equilibria for the way as I described it, where you lose money in the first period to gain money in the second period, but you do it only to the extent that there is enough, and there's enough. There's still enough uncertainty about your type, so that's why it has to be partial. Full pooling is an equilibrium, satisfies divinity. There will be no way, because any deviation from that, especially the full pooling equilibrium, where you extract the full surplus in the pooling outcome in both periods, is an equilibrium always. There might be partially separating equilibria, but the full pooling equilibrium is often the Pareto dominant. So that's the argument, that you will actually see pooling in this world and not be surprised. There's no reason to expect. This means that the pooling equilibrium has the feature that the H type will choose a low action in period 1. You're pooling. Since you're pooling, the patient will not pay you if you choose a high action. You won't get paid enough. So you're going to choose both types will choose a low action. The patient will be too suspicious of you. If there's a successful cure in the period 1, then patient will return in period 2, and you provide a high action and a higher fee. So we will see variation in quality across providers, but also within providers. I will treat somebody new differently from somebody who is old, or somebody who seems to trust me differently. If there was variation in trust, differently. Higher actions will be associated with higher fees. They know do grab. If over time I'm going to treat you, there'll be convergence in efficiency, because as I build my trust, I've always been successful curing you. You think I'm a good guy. What I say is going to be more, I'll respect it more. There's selection of providers over time, so efficiency does go up, even though there's pooling always. Finally, a positive shock to the reputation of a provider can improve performance. If I suddenly realize that you are actually a good guy. Now, this is an experiment, and the experiment is not perfectly mapped to this, but it's an experiment where randomly chosen providers were given 9 months of training for over a lot of training. We have a paper in Science where we show that this increased correct treatment by 8%, given that only half of them attended. The IV is probably a better measure of the scale. 13% increase in correct treatment. One thing I want to show you is that this is what I just said, which is that you get higher time spent, checklist, higher correct treatment, higher time spent. You also get higher fees, but it's never quite significant. Though I'll tell you something which makes it more closer to significant in a bit. Now, why should the training impact treatment? One is that there could be knowledge gains. And I won't have the time to show you this, but there is no knowledge gain. The treatment doesn't change knowledge. There may be a change in the perception of knowledge gain. Maybe even the providers are more confident. They believe that they have gained knowledge. I can't rule that out. But remember, or they could be that they have soft skills that also are improved. So they might be, or they might just be more principled. I have to do this. All of those would suggest that we would see so those would be supply side changes, or there could be demand side changes, and demand side changes could either come from the patient thinking that this guy, he went to the doctor, he must be better. It doesn't have to be true to be important. Or second, it could be that just the fact that he completed the training is suggesting that he's better because he's more committed, and we do see evidence of that. So I'll show you that there is no effect There's tiny effect on checklist, knowledge of the checklist, no effect on correct treatment as measured in vignettes. So this is the vignettes given to the same people. And you can see that the red line is the fit of, the mapping from baseline knowledge to attendance. And the more you attend, the better people are more likely to attend. So you could treat it as a signal saying, look, he went to the training, he must be a good guy. And you would be right in thinking about that. So there and the impact is concentrated as consistent with the previous one. All the impact comes from them, and this is also true. Now the price effects are also more likely to closer to being significant. So the price also goes up for the same reason. Going back to the two sets of explanations, it could be that there's the higher treatment and prices are either because the supplier is producing more and at the same cost to him. So he's just at the same amount of time he's being able to produce more. So you would get higher treatment and prices, but the relationship would just be shifted up. Or the treatment group, the mapping from treatment to prices would be then shifted up, or shifted down, or you could see movement along the same price production function. So you could see, and this would happen if there's just a shift in demand. There's no effect on supply. If there's an effect on supply, the supply expands, the relationship between effort and price should go down. I should charge you less for the same amount of effort because effort is cheaper for me. In that case, you would see an effect on quantity, or potentially at least, because the quantity would go up. The price, of course, then could probably go down, but maybe we don't see it. The alternative is that there's a demand side shift, that the people are actually saying, look, I want more from you. So in that case, the relationship between effort and price doesn't change. We move along that relationship. I offer you the same pair of choices, but you say, I'll take a higher price, higher effort. So quantities go up because demand has shifted. When reputation is the driver, this is what we should expect. So what I want to show you is this, which is that there is no shift in the relationship between checklist completed and treatment. So there doesn't seem to be any evidence of a supply shift. You're just moving the treatment and the control are exactly on top of each other. But overall treatment does better. Why? Because the points on the right are picked out. The demand seems to have shifted. That's fees and checklist. There's no difference it's not that the checklist completion is coming cheaper, it's coming at the same price, but now you are willing to take it more. The buyers seem to be more willing to take it. So skip all this. I have about 30 seconds left, so let me finish. So I guess I just summarize this, which is that reputational theory is consistent with these prices. But then what this is suggesting is, what do you do in a situation where reputation is a constraint? One problem is that that the medical policymakers in India just want all these doctors gone, except that they provide 80% of healthcare. So if they're gone, God knows what's going to happen. So they just want to eliminate them. Now that seems both wrong for the fact that there would be no one left, and second, because even the trained private sector doesn't seem to do much better than these people. So if you want to live with these unqualified providers, lack of training is a problem, but probably not the biggest problem, because they don't do what they know. What seems more important is some form of certification. So to help people build reputation, give them tests, give them and publish that. So make it, give them certificates they can show, so that people can actually follow, they go to the patients and say, look, I have a certificate, trust me, I'll get it right. So I think this seems like a market where certification could have a major role. It's not what right now the policymakers are keen to do. So I'll stop there, and I guess I'll wait for Roberta's comments and then questions.
Thank you very much, Abhijit, for being here and for this very interesting talk. Let me also thank my colleague for giving me the opportunity to discuss this paper. This is a presentation that has been prepared joint with some colleagues here. And before digging into the comments, I have a few, so stick to that. Let me just give a brief contextualization of the issue of poor health in low-income countries. And so if you think about one of the figures that is the most striking, think about like expectancy at birth. Even in 2019, you have almost 20-year of gap between the most poor countries and the richest country in the developed world. And so mortality rates are still very different between poor and rich countries. And poor health is not only about mortality, but is also about being in poor health during your entire life. And being poor health implies that you suffer from conditions that can be very damaging in terms of your ability to produce income, and so may imply strong poverty along your entire life, and so poverty traps. And the entire research agenda of Abhijit and Esther in the last decades have been helping in providing an explanation of why people are in poor health. And there has been a lot of research doing by the development community that try to understand whether this is due to lack of appropriate medicines or lack of appropriate vaccination, lack of infrastructure, lack of trained professionals, and all that is true. But there has also been a lot of work to try to improve over that. But even though those improvements have been going on more and more, there is another dimension, that is the dimension that has been highlighted by the paper today, that is the fact that you also have poor governance, and that even though you may have trained professionals, or those professionals are not there providing the right amount of effort to actually help patients. And so the line of research and the entire research program that has been presented today is very important, because it has been the first document the universe of providers of healthcare in low-income countries. It has documented the fact that you have a lot of low qualified practitioners, and that those practitioners are especially there in rural settings where people may start building issues of trust. But also on top of that, the fact that there is the existence of this no-do gap that seems to be extremely important. And even though knowledge has been seemed to be going up over time, if you compare the work of the co-author of Abhijit Das 10 years ago, knowledge was around 40%. The prevalence of knowledge was around 40% in similar sample in Delhi. The fact that knowledge goes up doesn't imply that good practices goes up. And so trust seems to be a key issue in context in which you have such a huge prevalence of undertrained professionals. And so I have a two set of comments today for Abhijit. The first one relates to the explanation of trust. So of course, given the setting, I definitely believe that trust is an issue. However, when you think about the context, the first thing I would think about why people are reluctant to increase the time they spend with patients is because time they spend with patients is correlated with price. And if people are poor and liquidity constrained, they may just not be able to increase the price. And I know that you have fixed effect relations in which you show that practitioners actually increase the time and they increase the price, but that could be just due to reverse causality. They increase the price when they can do that, but when they cannot, they just keep doing what they do. Then there is the issue of competition, and you showed us this very striking figure about people spending on average like 30 minutes of their time in clinics with patients. The question, this is really out of curiosity, what do these practitioners do? Could you explain us what their job? Because what you say to us is that basically they spend their time at a very low wage rate doing nothing. And one explanation could be that maybe even they would like to do more, especially in rural areas. There are physical barriers to be able to provide better care. Maybe when they need to shift to a more expensive level of cares, the equipment you need to do that is just not present in rural areas. And so maybe it would be interesting if you could provide us some descriptive statistics about the difference between lines related to primary care medicines that it's not expensive and lines related to higher levels of care. Like, for example, the equipment of linked to ACG for angina. Another comment I had related to more your theoretical framework is also the fact that for your lack of separating equilibrium and your Pareto efficiency in pooling, these two period models seems to be kind of key in the sense that if you have a longer time horizon and you don't this kind of time to match, then you may be willing to stay in a relationship with patients in which you separate. Think about doctors in villages when they keep interacting with their patients and through social networks as well, so reputation issues are there. Maybe in the long run, it's just more efficient for high quality doctors to separate themselves. So why actually the fact of actually separation doesn't happen in reality, especially if even in when doctors put low level of effort, the fact of being high quality implies a higher probability of you giving a better treatment. At one point, your patient should realize that you are not good enough. The last point related to the trust explanation of this gap is the way you measure the gap. So vignettes have been known in developed countries to provide underestimation of knowledge, in the sense that doctors in developed countries they put less effort in vignettes than with actual patients. So I was wondering, what are the incentive of those doctors in developing countries in India to put more effort when they are tested rather than when they are with the patients? And then the second set, and I'll try to, I have almost to conclude, but I have some other question on the way you test the model. And I think this is important because I think the way you test trust is very smart. You train people, you give a signal, and this is very coherent with the signaling literature about education. You give a signal of the fact that they are better. And this is fine, that's what you want to do. But then, as you mentioned at the end, another way that you could have tested that is to manipulate trust through certification. Through other way of signaling the fact that people are of high trust, for example, making the training more visible. And I think that would be needed to validate your test, because another explanation of the reason for which training is effective is the fact that you modify motivation or the awareness of doctors of the fact that bad treatment has very serious consequences. And so why didn't you randomize also on the visibility or on the certification to actually test the trust? dimension. Another way to randomize trust would have been to have a treatment in which you have referral from a friend that have been shown to be actually very trustable in developing country setting. And then this is really out of trying to understand the model. The outside option play a key role. Imagine that the outside option, instead of being hospital, is the fact of being poor. So at one point you run away just because you cannot pay for the treatment. Providing income transfers to poor people could solve the issues and could lead to more separation. And finally, a very few issues in which I would like you to comment if you have time. Otherwise, don't bother about these. The first one is, could you discuss about the non-economic implication of bad treatment? The health implications are massive, and you didn't discuss that. Then the human capital implication of all these. If you cannot gain your day out of doing good medical care, why should you educate? I know that there are barriers in education because the supply of education is limited in rural areas, but yeah, I'm more interested on the demand side. And then a few words on universal healthcare that basically would make the price of a medication less visible. You mentioned issue in developing countries about monitoring from the patient point of view, but this could somehow solve a trust issue if in the settings you described. And then what is finally, what are the implications for the COVID crisis? How much these trust issues matter the way India is suffering today during the pandemics? And I'm done. Thank you very much. This is extremely important and very, very interesting.
So in terms of the question of whether where does demand come from? Is this poverty? I think that's part of the value of the experiment is precisely that people are willing to pay more, or there seems to be more at least responsiveness. Now, there's other evidence on that, which is that people actually are, the number of visits to a healthcare provider are higher in India for poorer people. More people go to the healthcare providers more. So yes, eventually they don't go to the best hospital. So is poverty important? Of course it's important. But is it the case that at the margin they could spend a bit more money or a bit less money? My guess is yes. This is very cheap. Healthcare is very cheap. This is all operating at a minimum wage. So healthcare is very cheap. Could they? And when in the experiment we do find, and that's why I'm a bit hesitating to push that, because the effect is only if you have to squint really hard to see these. The significant, the effect is large actually. The effect on price is large. It's noisy. My guess is it's of the order of 10%, which is roughly the order of the improvement in training. So it's not small. So I think people are willing to pay more, and they do spend a lot of money on healthcare. A huge part of the amount of money privately spent on healthcare in India is very high. 6%, I think, of GDP is private spending on healthcare. So people are spending lots of money, including very poor people. That's widely been documented. What are the doctors doing when they're sitting around? They really are sitting around. And I think to me, the more interesting question is, why are they in that industry? And I think that's a result of just their absence of good jobs. So this is a free entry industry. You enter it because you don't have anything else to do. And I have a nice video for somebody saying, look, I qualified from high school and I had no job, so I became a doctor. I think it's more the free entry aspect of it. So that's related, goes back to this question of, better certification. I think your point about longer time horizons is very well taken, and that's sort of the discount factor. In a sense, the discount factor, if the discount factor is high enough, then the separating equilibria are going to be, at least for the high type, will be not be dominated by the pooling equilibrium. And so absolutely. On the other hand, it depends very much on the interaction of that and your ability to predict whether the person will get it better or not. If you're already in a world where it's pretty unpredictable, then the effective discount factor is very high, because your discount rate is very high, because effectively you think, okay, even if I do my best, probably he won't get better and not come back. Then the incentive to that pushes very much towards pooling. You just treat it period by period. Pooling is the thing you want to do. You don't worry about them coming back. So depends, I think, on how accurate you are and how confident you are. I don't know why the vignettes are why. I mean, I'm not saying at all in the vignettes they respond as well as they could. They might still be underperforming in the vignette. Maybe the knowledge is even higher. That's all I can say. The question of the interpretation of motivation going up, that's in a sense what I was trying to say by saying that there is, if that's the case, that basically then the way you'll attract patients is by cutting the price. And we don't see that. That was exactly the point I was making, is that was the reason. That's just one of the versions of soft skills. You can call it whatever you want. It's an increase in supply. If it's an increase in supply, so that I am actually offering you better treatment at the same, at a lower, at the same price, then maybe you'll take it. You'll say that, okay, I used to get 3 minutes for this money. Now I'm going to get 5 minutes for it. So therefore, I'll take it. We don't see that. We don't at all see the prices seem to have exactly the same relationship. So that's a sense in which I think this story is has to be about demand and not about supply. I mean, I think that improving people's outside option, I think that's a great point. I do think that would help, but I don't know. I mean, it seems to me that in terms of various, of the options we have, a certification, if there was not this ideological resistance, that seems like a cheaper option, one which I'm all for giving more money to poor people. So I wouldn't push back in that. Finally, on universal healthcare, so that's a complicated question. In some sense, India has universal healthcare. The public sector is, every village has a primary subcenter, a healthcare subcenter. So every village has one. Do they work well? No, they're closed 40% of the time. So universal healthcare, but so it's not so much about the formal supply side. The formal supply side actually exists at all levels. It is more about creating the right incentives. But then the right incentives, and that's why the work we had done with Esther and Angus a long time ago gets exactly into that issue. I don't know that we have a resolution of it, but we can. It's also, but one thing that's interesting is that what the government healthcare providers say is that nobody comes to us. We sit in the office day after day and nobody comes. Now, why don't they come? Partly because they are not actually allowed to treat many conditions. They're not allowed to give medicines for most. Like in the US, a nurse has only a certain kind of medicine she can prescribe. So it's not surprising. Maybe if people have a distorted sense of what healthcare is, which is often giving injectables, then you also handicap by insisting on proper protocols. That if a nurse is not allowed to give a shot, then she's, from the patient's point of view, she's not delivering. So this is a whole set of complicated issues. We have a recent paper from 2020, which goes back to that data and summarizes it, and I think it's probably on our web pages. If not, I'll put it there. Exactly going back to this question of what the issue is, but I don't have a. I mean, I think the universal healthcare question is complicated for that reason.
Yeah, if I can just add, my thought was, why don't trying to incorporate those untrained, unqualified into the universal healthcare?
That's the regulation question. That the position is shifting, fortunately. But for many years, the Medical Council of India, which is the medical regulatory body, took the view that these guys are illegal and therefore they shouldn't exist. And therefore you can't then integrate them. That's shifting actually with COVID, when you see the shift. So it's not, it may actually go in that direction of training them more, integrated.
Okay,
so
thank you very much.
Thank you, Abhijit. We don't have questions in the Q&As yet. I do have one question.
Go ahead.
So it's about network effects, right? We know that in low trust contexts, networks matter a lot, and even in rich countries, right? We use our relations to find good doctors. You didn't really talk about them. I mean, does this appear in your data somehow, and would there be ways to harness?
We don't have it. This data set has nothing on the patient side. That's the problem. The reason I didn't talk about it is not because I think, as Roberta said, almost surely is not reputation vis-a-vis an individual, it's reputation vis-a-vis a cluster of people. I have, my brother went and he had a good experience, so I came. So it's, when I talk about a patient, it's really not a patient, but a cluster of patients who each think that they have, roughly the same preferences, etc. So I think that's almost surely what's going on. We have no way of getting at it because the data set is completely a provider side data set with no information on patients.
Right. So
could there be a data set which was very different, or one that, like Roberta said, could we have done an experiment? The experiment we did was, it was done on a shoestring. The government paid for it, but on a very specific budget. So we had no money to do it, but could we have done another experiment where we shock parts of the network with reputation? Yes. I mean, I think these are all very interesting questions, but I don't have this data set, this work really doesn't have any way of getting at it other than just, when I use the word patient, I mean really a representative of a particular group of patients.
Thank you very much, Abhijit. Still no question in the Q&A,
okay.
So I think we can stop here. It was great to have you.
Thank you. Thank you for having me.
Thanks again.
Thank you, Roberta. Thank you for your comments.
Good luck with everything.
Thank you. Everybody stay well.
You too.
Take care. Thanks. Bye.